I am going to leave it like this again because there was a link that I want you guys to watch. It's coming up. I don't know which slide it's on, but we're going to go through that too. All right, so we ended on this slide on Monday. We talked briefly about pancreatitis and what things we're going to notice in pancreatitis. These two labs here, amylase and lipase, are going to be your most definitive indicator that you do have pancreatitis. If someone comes in from the ED or to the ED, they're going to run these two labs first. Okay, that's going to be their first line of defense. And will they be high or low? Okay, what does it mean when you have a high lipase and a high amylase? Think about what those enzymes do. What is pancreatitis? Inflammation, and it's also like a premature digestion that's occurring. So your pancreas is doing something called autodigestion. It's releasing these enzymes before it gets into the small intestine, and that can actually cause the pancreas to become inflamed because it's irritating it in that area. Which one of these labs would you guess, your best guess, would be more reliant on a pancreatitis? What is more, I mean, they're both pretty indicative of a pancreatitis, but which one is more definitive or diagnostic? Look at the descriptions underneath. Lipase. Lipase is going to be your better indicator. Reason why is because it's in there longer. Okay. When you have an amylase, it might just be a couple of days that it's elevated, and then your body gets used to it and it goes down. And so you have to catch it fairly early. And most patients don't come in right away because they have a small pain in their stomach. Usually it starts with pain, and they let it get to 10 out of 10 before they come in, which could be 5 to 6 days. Okay? Most patients won't come in just from a little pain. They'll wait till it's most severe. So lipase will be elevated for up to 2 weeks, and by then they usually come in. It's pretty evident that they do. You can do a urine lipase, but serum is just as accurate, and it's easier to get. You can also have a bilirubin and an ALK-Phos level be high. What does a bilirubin mean if it's high? What's happening in the body? It's not excreting it, so what could be a reason why it's not excreting it? Obstruction, okay? So that's what we think of with biliary dysfunction, meaning that there's a duct that's clogged or the liver can't produce it, and that's why your bilirubin shoots up high. What kind of symptom do you have with bilirubin being high? Jaundice. Yep. 2.5 is the number that you usually look for. I'm not going to require you to know that, but 2.5 or higher is considered, you'll probably look like you have yellow skin. ALK-Phos, same thing. Biliary obstruction. You want to make sure that if this one's high, you suspect that there is some obstruction somewhere in the ducts. Okay. ALT, that's the reason why AST is not on there is because ALT and AST are both liver function tests. ALT, think about the L in there, is a better indicator of liver. Okay. They both do the same thing, kind of like how pancreas, amylase, and lipase are good indicators of pancreatitis, but your lipase is a better definitive diagnostic. Okay. Same with ALT. ALT will be your first one you do. AST will come with it. White count, why would white count be high? It's an inflammation, right? You're getting irritated in that area. Just because someone comes in with a white count of 20,000, I'm not going to suspect pancreatitis unless they're having abdominal pain. Okay. Glucose levels directly related to your pancreas function. What does it do? Helps with digestion, nutrients. So if you're not actually digesting your carbs are going to shoot through the roof. Okay? So we have to monitor blood sugar levels. Calcium and magnesium, that can do with the digestion as well, and you'll find that those levels will be low because they can't actually be absorbed. Okay? So calcium and magnesium. What's a sign of low calcium? Trousseau. So what is trousseau? What's that mean? When you do a blood pressure, your arm will kind of curl up. Twitching is another good sign of low magnesium, low calcium. Chauvet's sign, whenever you have the twitching right on your cheekbone. Okay? So those are things that you can look for by not even seeing if their labs have come back yet. Okay, so how are we going to diagnose pancreatitis? With liver function, we can easily do an ultrasound. We can see a beautiful picture of the liver with just a simple ultrasound. With the diagnostic for pancreatitis, ultrasound is not the best option. So don't put that on the exam for this one because it's not the actual best diagnostic. The first thing that they'll probably do is an x-ray, just to make sure there's no underlying pneumonia, because what kind of pain would you have with pancreatitis? It's going to be about right here, but where can it radiate? Left or right? Left. So you might suspect heart dysfunction, pneumonia potentially in the lung, and so they'll do a chest x-ray because it's easiest. If they don't find anything, they'll do a CT scan, okay? That's when they inject the dye and it lights you up so you can see every part of your organs, okay? Abdominal ultrasound can be done if the underlying problem is an obstruction. So if the obstruction is causing the pancreatitis, then you could do an ultrasound of your abdomen to see if there's any ducts that are obstructed. Okay? That's the reason why you would do an ultrasound. And then MRI, I don't think I've ever had a patient get an MRI done for a pancreatitis because we find it in a CT scan. There's no need to do anything further unless they suspect there's cancer. Then they might potentially do an MRI or a PET scan.
So the first thing is always
Yes, which that's going to be standard in the ED because they're not just probably going to go down for a CT unless they suspect that it's really bad. But CT scan and chest ray are pretty comparable for first ones. Just know that ultrasound is not the first one for this problem. But if you have gallbladder stones, ultrasound will be the first one. Okay. So the first thing we're going to do, let's say they come in with 10 out of 10 pain, but they just said that they came from their Super Bowl party, they had a lot of fried food, lots of beer. What's the first thing we're going to do? Are we going to give pain meds, or are we going to make them NPO? We're going to make them NPO, make sure they don't stimulate any digestive system. Pain is important, I will say that it is, but pain can wait, okay? I'm not saying that we shouldn't be cautious of their pain because it is the fifth vital sign, but when you think about NPO, what's making the problem worse? Putting something in that mouth. So if they come in and say, I'm just dying of thirst, I need some water right now, and you haven't gotten any orders yet, do not give them anything, okay? You have to say, we have to wait for the doctor to make sure that he doesn't want you to be NPO. Because if they drink 2 or 3 cups of water, they're going to be hurting. Even though it's not high fat or caffeine or alcohol, it's still stimulating your digestive system. Okay, so no food, rest of the GI tract. What's another order you could suspect to put in their nose? NG tube, what does that do? Right, so if your belly is really full or there's air in there, it's like stimulating your GI system, or we need to pull things out. Say they binged on food for a whole day or two, there might be some potential to get rid of those contents so they don't actually have the digestive system working as much. So NPO initially, we want to put them on their left or right side, just a fetal position laying. You'll be surprised how well that works with people with pancreatitis. I'm not sure the actual background on it, but if they lay on their side rather than their back or on their belly, they actually feel a lot better. So we tell them to do a side lying position with their knees kind of coiled up. TPN would be the first thing we would start. We would not start NG tube feeding. Okay, does that make sense why we would not do that? Okay, we're going to put something in their GI tract. They're not going to be able to digest it. It's going to be painful for them. So we start with TPN. Then after 4 or 5 days, because it's going to be a while, they will be in the hospital for a couple days. Then we could start maybe slowly putting in some NG tube feeding. Okay? And then we talked about the NG tube. You've seen this slide 3 times now, right? These are the pain management or the drug management for these types of problems. You'll find that they're very similar to each other, okay? This slide, I think, has been, maybe not the antacids, but the anticholinergics, the somatostatin, and the opioids have been on 3 slides already, okay? So you may look like you're having tons of meds, but they're all the same, okay? Opioids, what's significant with that? If we give too many opioids, respiratory depression we can look for, and also GI tract can slow down, which we kind of want, but we also don't want that to cause an ileus. Okay, sometimes that can cause ischemia to the bowel, constipation, and we don't want that problem on the other side. Most people will be in pain for 3 to 4 days at a 10 out of 10 pain, you guys. So sometimes it doesn't matter what we give, it's just going to have the worst outcome because they're in so much pain. The best thing for them is to make them NPO, and that will cause the pain to go away. Let's say after a day they say, oh, I feel great. And then the doctor says, well, we still have to wait to advance your diet because the whole point of why you're in here is because of all the food or fatty intake, alcohol that you've taken. Some might say, okay, well, fine. And then the next day they take a clear liquid diet, sips of water, and they start to have significant pain. What's the doctor going to do? NPO again. Sorry, man. You're not going to eat anything for a couple more days because it shows that your pancreatitis is still bad. What's another reason why we could advance diet? What's another sign that we would say, okay, it's time, besides patient feeling better? Not necessarily. Thinking lab-wise, what are we looking for? We're looking for a decrease in lipase and amylase, right? If you're going to have a lipase and amylase, I'm trying to think of which one's which, because I don't know exactly the normals. I know that like 70, I think, is lipase and 100 is amylase. If they're 300, you're not going to be feeding that person, and they'll have daily amylase and lipase readings, okay? You're going to wait till they come back to normal. Are they feeling good? Are they doing all the necessary measures, and then feed them? And that can take days or even weeks. Antacids, has anyone given Protonix or Nexium in the hospital? Absolutely. Probably one of the number one people that come in are GI bleeds. People have a risk for bleeding or clots. We give Nexium or Protonix, and that's a proton pump inhibitor. It's going to coat that stomach to hopefully prevent any type of bleed in there. Prilosec, Zantac, has anyone ever given those? Okay. Zantac is going to be one that we're probably going to give by IV. You can give PO, it's not bad, but IV, especially for patients with pancreatitis, because Zantac, we want that to work extra good. Okay, so normal dosages for that, we're going to see about every day, we'll give one IV piggyback dose. Okay, it comes in a little bag, it's not a push, it's an actual drip. Okay, they can do every 8 hours, and that's for people that potentially might have a better like younger people that excrete it faster, and we might want to give it in smaller dosages, so then that way they can get it throughout the day. Okay. Anticholinergics, this one isn't probably as common. I don't think I've ever given Lomine, but I have given the Bentyl. It's going to decrease GI motility and help with the pancreatic enzymes. Okay, it's going to help them not be produced as much. Somatostatin, I have given that. That is like the oldest med in the book. Some older physicians really like it. It's comparative to a Protonix drip. Okay, if you've ever given that, it's very similar. It's going to help with the pancreatic activity to slow it down, but it's shown that after time, it's kind of an older drug, new ones are coming out that are better. So I wouldn't focus too much on somatostatin. Just know that they do give it for pancreatitis. Okay, surgery. How many times have you seen a person with a post-op pancreatectomy? None. Most people don't get their pancreas taken out, and the reason why is because what is your pancreas reliable for? Digestion, nutrition. You can't live without your blood sugars being maintained. Some cases you'll get your pancreas taken out, and that's if you have a donor ready to go, you're a complete match, and also if you're probably diabetic. It's probably not for chronic pancreatitis that you would get a new pancreas. It's more for people that have had diabetes their whole life, and they manage it well. It takes a lot to get a pancreas, okay? You have to make sure that you're managing it well, you're not having exacerbations where you're going high, low, and making sure you're not a fragile diabetic, okay? Obviously, these people need it the most, but you have to show that you're taking care of yourself to get a pancreas, and that you have no other cancer process, liver dysfunction. You have to have just that problem. Okay? If you do, for some reason, have surgery, which I said is very rare, but if you do, they will put an NG tube down your nose to decompress the stomach. Start you on nutrition and IV fluids. T-tube, do you remember what T-tubes are? What do we use them for? Yep, they can go into your ducts to help release that bile. They might use that if there's an obstruction somewhere causing it, just to kind of, because they're going to manipulate that area. So they might put a T-tube in. We'll remember before and after surgery to tell them about good measures to breathe. We want to make sure that we're telling them to prevent pneumonia. Also making sure after surgery they get up and move to prevent what? DVTs, right? Clots in the legs. Splinting. Why is splinting important? We're not going to do a laparoscopic. Well, sometimes they could do to drain things, but they're not going to do a laparoscopic pancreectomy. Okay, they're not going to just pull out the pancreas through a little hole. They're going to have to open you up. Okay, so you have to make sure you split when you cough after surgery, and let them know that because they could become eviscerated after surgery. This is pretty common. They'll go in and they have abscess or little cysts on the pancreas. Sometimes that happens, and that's the most common surgery they'll do with pancreas is they'll go and drain those cysts. Okay, those can clog ducts and make it hard for digestion as well, and so that's pretty common. But the actual part where they take out the pancreas, that's only for certain people, and it's very rare. This next procedure, I'm not even going to attempt to say that word because it's probably not going to come out right. It's also called the Whipple procedure. Remember this word, remember Whipple procedure. You have to know how it works on the exam, what you expect, and what complications you would see with a Whipple procedure, okay? And we're going to watch this video. It's a perfect video on what I want you to know for the exam. There is a couple more slides on, I think it's like 5-10 slides or so, and it actually goes through like what is happening during a Whipple procedure, but this video does a very good job.
My name is James Lee. I am a surgeon at Columbia. I'm the chief of endocrine surgery here at Columbia and a surgeon in the Pancreas Center. The Whipple procedure was actually developed here at Columbia by a surgeon named Alan Oldfather Whipple. And over the generations, the Whipple procedure has really been perfected at Columbia and has been pushed into new territories. For example, our current director of the Pancreas Center, John Chabot, is one of the true pioneers in portal vein resection reconstructions, which is allowing us to offer the Whipple procedure to a larger percentage of patients with pancreatic cancer. The Whipple procedure can be used to treat a variety of different diseases, both benign and malignant or cancerous. The choice of using the Whipple procedure depends primarily on the location of the tumor or the location of the pancreatitis. If tumors or pancreatitis is located in the head of the pancreas or the uncinate process, oftentimes a Whipple procedure will be indicated.
Okay, so that's significant. Where's the cancer located? That's one reason why you'll use or do a Whipple procedure. If you think about the head of the pancreas, what side of the body is that on? What does the pancreas look like? Kind of looks like, it might even show you too, but it looks kind of like this. Kind of has a head that looks like this, okay? And then it goes off into your small intestine, right here. That's where the digestive enzymes go in. This is the part of the cancers that they're talking about. If there's cancer everywhere in the pancreas, this isn't going to work. It has to be a small amount, and it has to be in the head of the pancreas, okay, for this procedure to work.
We'll talk about the basic steps to a Whipple procedure. In the Whipple procedure, we start by entering the abdomen through an incision that we make in the upper midline or the middle of the belly. In order to expose the head of the pancreas and the duodenum, we'll move the colon out of the way. The duodenum wraps around the head of the pancreas, and these two are pretty well stuck together, so we have to remove, if we're removing one, we remove both. We start by performing a Coker maneuver, which is to free up the duodenum and head of the pancreas, and this allows us to identify the inferior vena cava. The vena cava is the largest blood vessel in the body and carries blood from the lower half of the body back to the heart. Next, we'll remove the gallbladder. We'll divide or cut across the intestine in two places, as well as the neck of the pancreas and the common bile duct, and remove the specimen. We'll send this off to our pathologist to make.
Look how much they take off. That is a lot. That's a big procedure. If you're taking off that much bowel, what can you expect to maybe be a complication? Constipation, so an ileus, okay? You're manipulating that small part, especially the first part of digestion, what your body has known as for your entire life, the first part of the process. If that is taken out, sometimes it can get stuck, kinked, coiled. So you're going to expect maybe some diminished or absent bowel sounds. Diminished at first, but you should never get absent because you can suspect an ileus. Okay, so if there's an absent bowel sound. But they take off a good portion of that head of the pancreas.
Sure, we remove the tumor. Next, we put everything back together, and we do this by putting a piece of intestine and connecting it to the pancreas, called a pancreaticojejunostomy. We connect the bile duct to the intestine, called a choledochojejunostomy. And then finally, we'll connect the stomach back up to the intestine, and this is called a gastrojejunostomy.
Okay, so just kind of briefly look at what's going on. So you know your three parts of your small intestine, your duodenum, which is gone now. They don't have a duodenum or duodenum, however you want to say it. Your jejunum is your second part of your small intestine. That's what's going to get pulled up to your stomach, and they're going to kind of kink it around like that, so then it can be, I guess, a better option of putting it inside that intestine. And they're going to make sure that that is all connected. okay? So you have a pretty massive surgery, pretty high risk for infection because you've manipulated all those organs, moved them around, could have punctured certain areas. Think of all the places that they have touched or potentially poked through and cause a perforated bowel, okay? If you have a perforated bowel, what could potentially happen? Poop could go inside your perineum or your abdomen and cause sepsis. You can go into a state of shock, okay? So that could happen.
One variant of this operation is to leave a little bit more of the intestine, and this is called a pylorus preserving Whipple, and we'll connect the pylorus up to the intestine. So that's the Whipple procedure in a nutshell, and the Whipple can be done in a variety of different manners, both as an open operation, which is the most traditional way, and some groups are using both a laparoscopic and robotic.
Which, I don't know, that's probably pretty the laparoscopic to go through those holes, because they can use robotics now instead of people. I swear in 10 years we won't even have surgeons anymore, because they're starting to use more robotics, and they actually use, it's like I don't know why a doctor, maybe it's because their hands are not steady enough, that could be a reason, but it's almost like a video game, and the doctor's on the outside of the body, he's not even touching the patient, and he's almost controlling the robotics to do the surgery for him, because they probably have a steady hand, smaller fingers, or smaller, digits to get inside the body, and that's probably why they can do a laparoscopic, because you can't really, with someone's hands, you have to like almost grab and get it out of there. So that's the Whipple procedure. With the Whipple procedure, we talked about kind of simple complications that we expect to see on maybe the exam. But you need to know generally how that works. Maybe not specifically like this is attached to this is attached to that, but kind of know exactly where it's located, what you're dealing with, and why you would get it. So the number one reason why you're going to get a Whipple procedure is what? Cancer, okay? So if you have cancer, there is a chance that in small populations, not a big percent of the population, that you could have this procedure done, okay? So it's something to think about if you have a patient with pancreatic cancer, they might potentially get this procedure done, okay? And this is on your PowerPoint in the comments or notes, so if you want to go back and look at that, you can. Because sometimes the sound is not the best when you record your video. Okay, so after pancreatitis surgery, potentially if they went in and drained one of those cysts or abscess, there's a potential that there could be some bile leakage. If you ever get bile in the skin, it excoriates it and it's very potent on the skin. So skin integrity and making sure that that bile is not leaking is essential. And so that's what you'll be looking for. Sometimes they get a T-tube put in and they can have it draining. And so if they do have a T-tube, there is a potential for the bile juices or the bile acidity to get on the skin. So you will be watching for those types of skin breakdown. Okay, nutrition. If a person does have pancreatitis, that's the first thing we should be thinking about. Most patients that come into the hospital, we're not going to say on day one, let's start TPN. But with pancreatitis, we might, because we suspect they'll be here for 4 to 5 days minimum, and we have to think about it early because they're going to get angry at you. They're going to get really mad when they can't eat after a day or two, okay? It's one of those patients that you don't really want the first 2 days. After about 24 to 48 hours, they don't have hunger anymore because it gets to the point where their stomach shrinks and they just like, you know how it feels when you're sick for a couple days, you're not even hungry because your stomach has shrunk so much. Or the first meal you eat, you have a couple bites and you're full, okay? So definitely NPO in the first part of the stages, and then we're going to start TPN. What can TPN do to your blood sugars? You can make it really high because we put lots of carbs in there. That's what we want. We want them to stay nice and meaty. We don't want them to lose weight. And so we want to make sure that we're doing blood sugars. I don't care if they're not diabetic. They have to have blood sugars on their MAR or on their interventions. For GI or for TPN, twice a day is fine unless they're having lots of spikes. Then we would increase it with their meal, or not meals, but 4 times a day. Why do you think NG feeding is on there with pancreatitis? When do you suspect we would initiate NG tube feedings?
3 or
Yeah, 3 to 5 days, depending on the patient. We can do that. We like to start that first because most of the time they have an NG tube in there anyway, so we just will use it, okay? So we use that NG tube to start. What kind of diet are we suspecting? High carb, low protein, low fat, okay? They won't get any caffeine, no alcohol, of course, in the hospital, sorry, but no alcohol, no spicy foods. Nothing that's going to irritate the GI system. Okay, but high carb is the only thing high. Everything else is low protein, or protein and fat. Okay? Small frequent meals once they actually start eating again. Are we going to start them on a regular diet after 3 days? No. Clear liquids, maybe go to a brat diet, soft, full, we'll go very slow, okay? If they have pain, we go back. So if they had pain at soft diet, we go back to clear liquids, okay? Just how it is.
Why does it say ATI?
There was a question on ATI about, it was a chronic pancreatitis, and it said to increase proteins. Does anyone remember that question? I asked Karina, Becca, we looked in the book. We could not find any resource that shows why you would increase protein. Because with all these patients, we tell them to decrease protein. Okay? We don't want protein because that's going to cause your digestive system to work overload. With chronic pancreatitis, we could maybe assume they're on enzyme replacement. Okay? So we could increase their proteins because they actually have the enzymes to digest proteins. That's the only research I have found. On the exam, everything's low for protein. Okay? Don't put high, and don't argue with me because ATI said it, because we've looked everywhere. I can't find one resource that says it is. And I even got the big dog, Karina, involved. And she said that she couldn't find a source at all. Okay? So the ATI question, if you haven't done Prep U yet, or not, is it ATI? It is ATI. If you haven't done the ATI yet, don't put that as your answer. It's like a question with chronic pancreatitis. And it says to increase proteins. Okay? Let's see here. We talked about avoiding spicy foods, caffeine, alcohol. When they go home, let's say they're an alcoholic, we need to really stress no alcohol. That is going to be very difficult, and it's nearly impossible for some patients because they come into this every 6 weeks, just 3 months. It's like a reoccurrent every single time. It's kind of frustrating because you know why it's happening. You know it's because they're an alcoholic. We can tell them about all the resources, social services, AA, counseling, but they have to want to do it, you guys. We can't hold their hand and take them there. There can't be a court order that says you have to take AA. Can't do that, okay? So they have to make sure they want to do it. Ensure and Isocal are just supplements that they can take if they're losing weight, because it's pretty common for these patients to lose weight, especially alcoholics. They don't eat anyway, okay? That's all their diet is alcohol. So we need to get the appropriate nutrients. Okay, so here's our chronic pancreatitis. Acute is going to be, not usually, but one episode. It's one single episode where they come in. Some people could have a pancreatitis and never have it again, essentially. But since they do have the high risk of having pancreatitis for even one episode, most likely they're going to have it again. Okay? Mainly because of the risk factors and also their habits, if they're alcoholics or if they are not taking care of themselves. Pancreatitis for chronic is just diagnosed as recurrent, and it gets more severe with every attack. So just because the first one wasn't that bad doesn't mean the next one and the next one is not going to become worse, because it will with chronic pancreatitis. And usually it takes longer for them to get back to their normal after they've had one attack. Drug therapy, what kind of things would you suspect with chronic pancreatitis they'd be on forever? What type of meds? No? PPIs, they'll be on like Prilosec for the rest of their life. They'll have it every single day. Potentially pain management. These people may not have pain every day if they're chronic pancreatitis, but a lot of days, okay? They might have little flare-ups here and there. If they feel like they are flaring up to the point of hospitalization, which they know if they're chronic pancreatitis people, they should come in to make sure that they're helping their body. They know it when they come in, they'll be NPO, so some don't like that, and so they know kind of what to expect. But you'll find that your chronic pancreatitis people, when they come in, they just hate it. They hate the hospital because they can't eat. It's not fun. They're having a lot of pain. But some say, I need opioids. I need narcotics because my pain is that bad. And I do believe them. Even though they might be abusers, if they come in and they have pancreatitis and it's true, they do have excruciating pain. So I will give them pain meds, and I won't hesitate about it. Enzyme replacements, they can get a couple different ones to help with the pancreas digest those foods. What would happen if you didn't have enzyme replacement on board? What kind of things would you see on symptoms? What's that? Potentially, yeah, because you're not actually digesting anything. It just goes out. Coming back to stools, what do you look for? Fatty stools. What's that special word? Diarrhea. It's going to be fatty stools. So that means the fat that you ate didn't get any absorbed in the nutrients in the body, goes right through the system, out through your bowels. Okay? Insulin therapy, because if the pancreas is chronically stimulated or not working, you can have problems with your blood sugars being high. So they might not even have diabetes. It's probably because the pancreas is not working for that reason, which is what diabetes is. So they could potentially down the line be called a diabetic. Okay. Diet therapy, what's our diet? What are we going to tell them to go home on? High carbs, low protein, fat, what about fat? Low fat, no spicy, no alcohol, no caffeine. Okay? Doesn't mean they can't have a little bit, but minimal, okay? It's hard not to have fat and protein. That's a lot of foods, okay? So minimal things, or not every day. Okay, so these are the symptoms you're going to see with pancreatitis. Of course, pain. Where is it going to radiate to? Left shoulder, left upper quadrant. We need to rule out MI potentially if the patient comes in, unless we know this is recurrent and they have it all the time. Okay. Ascites can be, especially if there's an obstruction, some liver failure. If there's a mass present, there might be some mass shown like on a CT scan. If there's a lot of ascites, breath sounds can be affected. If the pancreas shuts down, respiratory is shown to have a lot of effects. So you could be dyspneic, shortness of breath, trouble laying down, breathing. Our fatty stools and also clay-colored stools. Why do you get clay-colored stools? Bilirubin. There's an obstruction somewhere, right? The bilirubin can't get through, so then your stools become clay-colored. That's why little babies, when you see their white stool come out, it's not something to get alarmed with in a child, like a small child, like 10 days old, because their liver is one of the last ones to essentially develop. And so it's pretty common for them to have clay-colored stools occasionally until they get more mature. Weight loss, why would they have weight loss? They're not absorbing anything, right? They're eating it and it's going right out. Jaundice, just because of the failure, and also dark urine. And then why would you have the 3 Ps? We're learning still endocrine, diabetes. Okay, what do those words mean? Pee a lot, eat a lot, and drink a lot, right? So if you have those symptoms, you could still suspect pancreatitis because it's related, okay? They're having those problems. Their blood sugar is high. Okay, what are we going to do for pancreatitis? How are we going to fix it? There's something called an ERCP. We talked briefly about this in liver and what you can do. It's kind of like an EGD where they go down the esophagus, but they can go further than just the stomach. They can go into the small intestine, the common bile duct, the liver, and even into the pancreas. Okay, so they usually go to look for an exploration. They look to see if there's a tumor, an obstruction, a duct that's not quite draining right. They don't really do much treatment. It's more of a diagnostic. It's to go in and look around. Okay? For chronic pancreatitis, you're going to have your amylase and lipase be high. That's your number 1 and 2. What's more definitive? Lipase. Elk-Phos, if there's an obstruction, bilirubin could be obstruction as well. And then your glucose will be high because your pancreas has shut down and not worked. Okay? And then you could do an ultrasound, but remember the ultrasound is not as definitive as the liver and looking at gallbladder and stones. Okay, you will have to, that's one thing on this exam, you have to know your meds. There's not a lot of them, even though that page may have looked different. A lot of them are similar in how they work. Okay, so you might have 3 meds that are essentially the same, it's just different names, and kind of knowing how they work. But opioids are going to be probably one of the common ones you're going to see with all these problems because they all cause pain. Okay? These are the enzymes that you would get with pancreatitis. I wouldn't necessarily focus too much on the names. It's pretty obvious that they're enzymes that they're breaking down. Does that make sense? It's the pancreas enzymes. And so those are going to help with digestion, making sure that you're actually fully absorbing the nutrients. Something significant, I want you guys to know these, is do not mix with high protein foods. Well, we know that already because we're not supposed to have protein. But also because it can make your stools very watery, and we don't want that as well. So we want to make sure protein is not high in this person's diet. Okay? And then obviously we want to make sure their stools are getting less fatty, which they have to tell us that themselves if they're not in the hospital. Okay? Insulin therapy, if they are truly becoming diabetic and their pancreas has shut down, we will make sure that we start them on oral hypoglycemics and also insulin. So it's not uncommon to send home on insulin after their first visit, even if they are showing spikes and declines in their blood sugars. Okay? TPN, you can also add insulin to your TPN. the pharmacy will do that for you. Some smaller facilities like Wagner potentially might add it to themselves, where you'll say add 10 units of insulin to your TPN, and they'll get that over 10 hours. Okay, so this helps with those blood sugar spikes. Okay, diet therapy, we might actually have them on TPN at 4,000 to 6,000 calories a day, which is very, very high. And the reason why initially, and especially over a while, they don't actually absorb much. So we have to give them tons of calories and tons of carb intake. Okay. Surgical management, we're probably not going to do that first, if anything. Pancreas usually getting taken out is not your first line of defense. We usually tell patients that it's not even an option unless they are fairly healthy and that's your only problem. But most of the time it's for uncontrolled diabetes mellitus, usually not for cancer, only because if you have pancreatic cancer, it's because it's probably spread or there might be a potential for metastasis, and they know that your function is not very well. Okay, so that's probably a reason why you wouldn't get a pancreatic transplant if you had cancer. Okay, the client has been hospitalized with pancreatitis and is being discharged home with home health services. The client is severely weakened after his illness. Which nursing intervention is the highest priority in conserving the client's strength? I'm going to tell you one thing. There's like 5 questions coming up. I don't really like any of them. They're not going to be on the exam. This is just to kind of enforce the teaching. So I wouldn't focus on the exam, these questions specifically, because I think some of them are worded kind of poorly, and some of the answers aren't the best. But I think there's a couple of them you could pick 2 answers and argue about them. But the answer for this one is A. Okay, limiting their activity to 1 floor. They are going to be more fatigued. Think about their diet. They're not actually absorbing the nutrients. They may not be able to get around as easily as others. There's no sign of respiratory distress, so we wouldn't do anything with oxygen. Instructing the client to take PRN sleeping med, probably wouldn't do that just because they potentially could have problems with sedation and sleeping. Arrange the client to have a nutritional consult, maybe. That might be something that we might do, but for priority, probably keeping everything on 1 floor, which I don't know where they live. They could live on 3rd floor in apartments, so that could be very difficult. The client has developed acute pancreatitis after also developing gallstones. Which is the highest priority instruction for this client to avoid further attacks of pancreatitis? What do you think? B, right? See your doctor right away if you're experiencing symptoms of a gallbladder attack. Most of these people that have had them before, or they know the symptoms, they know what they're looking for. Don't wait, because then that can cause ischemia and a necrotic gallbladder. The client has been discharged to home after being hospitalized with the acute episode of pancreatitis. The client, who is an alcoholic, is unwilling to participate in AA, and the client's spouse expresses frustration to the home health nurse regarding the client's refusal. What is the nurse's best response? This is the one that I think is dumb. I don't like this question, but this is straight out of an NCLEX book. And sometimes it's frustrating because I don't really agree with some of the questions sometimes. Main thing is with many patients is to stay non-judgmental. Can't make them do anything. I mean, unless you have a doctor's order for something else, but you can't force them to do anything. And also don't ignore anything. So that's why C is the most correct, because you can provide information for them, you can educate them all they want, but you can't make them do anything. Okay? Unless they're doing something illegal, like drugs or some sort, but you can't force them to go into AA just because they don't want to. The nurse is assessing the client's alcohol intake to determine whether it is the underlying cause of the client's attack of pancreatitis. Which question will the nurse ask to elicit this information? This is the judgmental one. I do agree with this question. Did you guys learn in your first year, if there's ever an answer that says tell me more, that's probably the answer? I would say probably 90% or even close to 100 on your NCLEX. If there's one that says tell me more about how you're feeling or tell me more about blah, 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 it's probably the answer. Because what does it do for your therapeutic communication? Open-ended, okay? Instead of being more judgmental and say, do you usually binge drink? Yes, no. You're not getting information. Do you tend to drink more on holidays or weekends? Well, that's implying that they drink, period. So that's kind of being a little judgmental. Say, well, you need to be more open-ended, like, tell me about your drinking patterns. Do you drink? That kind of questions. Estimate how many episodes of binge drinking you do in a week. There are some standards out there that say what's normal. Some farmers will come in, this is very standard, and say, I have one drink a night. What's one drink? Because I see those Bubba kegs, that's one drink. Okay? They will say that, and they'll have a tall glass, that's one drink. What is one shot? Maybe they pour half and half. Okay? You have to be very specific about what they're drinking. Because I would say probably some people would say I have 3 drinks a night, but they're having stiff ones. Okay? So you have to be very specific. The nurse suspects that the client may have acute pancreatitis as evidenced by which group of lab results? This is a very good question. It's probably what you'll need to know. Okay, so we're talking specifically about pancreatitis. On the exam, don't get confused with different diagnoses and labs because they're all going to start running together. What are the labs that you're going to suspect with that diagnosis specifically? Okay? Don't start thinking, well, geez, the pancreas can be obstructed and then it can go to the liver and then everything's affected. All these labs are right. Think specifically for that problem. Okay? If I have specifically an obstruction, you're going to think ELK-Phos, right? That's going to be high. Or you might have some increased liver functions. With pancreatitis, you're going to think amylase and lipase. Think of the pancreas actually being destroyed, so your glucose, your white count could be high. Okay, so C is the correct answer. That's one problem that I did in nursing school too. I overanalyzed every question, and I thought, well, if they have this problem, they could have this, this, and this. And so I started thinking, well, these labs will be there. That's good critical thinking for the overall picture, but when they don't give you the information in the question, that's where it gets frustrating. You don't know that information, so you assume that it's not known. The nurse is caring for a client recently diagnosed with type 1 diabetes who has had an episode of acute pancreatitis. The client asks the nurse how he developed diabetes when the disease does not run in his family. What is the best nurse response? Right. You can get diabetes from having a destroyed pancreas, and it would be type 1 because your pancreas doesn't give anything. It's done. It can't do anything else. Okay? With type 2, that's when you have an actual problem with there's a blockage, and usually weight loss can help sometimes or reverse it even. And so that's why type 1 is the answer, is because of people that have complete shutdown of their pancreas. The client is experiencing an attack of acute pancreatitis. Which nursing intervention is the highest priority for this client? Right. This one's kind of tricky because you're going to see this a couple times on the exam. You're going to say, what's more important, pain or being NPO? NPO is more important. Okay. The client has been placed on enzyme replacement for treatment of chronic pancreatitis and teaching the client about this therapy. The nurse advises the client not to mix enzyme preparations with foods containing which element? Think specifically with enzyme therapy. Right. High protein is bad because what can it do to your stools? Watery. It is D. Sorry, it is D. It probably is. Yeah. Was it on the side?
No, it was like
So you're probably like, what the heck is she talking about? No, it is D. So high protein is bad. Sorry, I think that was on the recording wrong. So D is the correct answer. All right, why don't you guys take a quick break and we'll finish up and then we'll review.
All
right, so the last bit of information, this is 9 slides, not very many, but 3 quick questions. It is a small portion of the exam. I think there's just one question on this, I believe. So we'll just kind of go over it pretty quickly or briefly. Pancreatic carcinoma, I'm sure some of you or many of you have known someone with this diagnosis. It is fairly common. It's the fourth leading cause of cancer death in the United States. So it is one of those diagnoses that you don't necessarily want to get because the 5-year survival rate is pretty low. Okay, it's pretty hard to discover in early stages. That's another reason why it is so deadly, is because most people don't find it right away. I don't know, fire alarm's going off. Oh, okay. But like I said, it's it's highly deadly, but only because it's so metastasis. It goes very quickly to different organs, especially the liver. Liver is a very common one that it spreads to first. Lungs is another common one that it goes to next, and then the brain probably being the last one. These are some symptoms that you're going to see. Probably the most common will be jaundice. It's not going to happen, like I said, the first day that this occurs. It'll be over time, but you can see different changes in stool pattern as well. Skin is dry and itchy, probably because of that jaundice that is on the skin. Do you guys remember the med we give for jaundice on the skin, or those bile salts? Questron, okay? Questron is given 4 to 6 times a day. It's going to help with the bile salts that accumulate on the skin, and that's why people get that dry, itchy skin. We usually try to tell people not to itch their skin because they have a high risk for infection, so we tell them not to itch their skin directly. Liver and gallbladder enlargement, so we look for that on palpation. What other things would we look for when we're assessing? Percussion-wise, what are we going to hear? Or not hear, but when you're doing a little percussion. What are you going to note? Dullness. It's going to be dull because it's so enlarged, okay? So that'll be things that we look for. If it spreads or if it's bad enough in the pancreas, your blood sugars could be affected and you could become diabetic. They're usually pretty weak and fatigued. They do have some dull pain usually. It probably gets worse with the worst diagnosis. And they can have a lot of weight loss as well because of the malnutrition. Let's see here. That's probably the most significant ones. Drug therapy, you've seen the opioids many times, but they are going to be in excruciating pain. We like to give them opioids firsthand. We do not start with baby drugs. We go right to the good stuff, mainly because prognosis is poor. We do not want to make people dependent on narcotics, but if their quality of life is not good or they're not going to make it, we want to make sure they're comfortable. Okay, that's one thing I will not restrict with cancer patients is pain meds. I will give them as much as they want. Okay, I don't care if it's to the point of them passing away. If they're comfortable and they want to pass away with dignity, that's what I want to do. Okay, I don't want them to be there screaming out in pain. They can do some chemo and radiation, very common. Most of the time it doesn't do much. It just shrinks the cancer. Okay, so it basically buys them more time. The only thing with radiation we don't like to do is give so much to the point where they're having skin breakdown, and they already have that dry skin anyway, and it's also going to cause more problems with obstruction, nutrition, and so it actually makes them feel worse. But sometimes the patient really wants to do everything, and they try, and it could be a year, or 2, but most of the time 5 years the rate of what it usually, I shouldn't say time frame, but that is usually the 5-year time frame. They can do some stents when they put in for an obstruction if that's causing some of the ducts to be clogged, and that can cause a lot of pain as well. So if you put stents in, that can just help relieve pain and help with the bile flow and help with nutrition. But the main thing is going to be drug therapy because we want to make them comfortable. There's not much to actually cure this problem. Okay, we can do a partial pancreectomy where they take out small parts of the tumor if there's a tiny bit affected. If you get it really early in the process, this is great because there is some success rates with early diagnosis, and you can actually get rid of pancreatic cancer if you find it early enough. But that's the problem. It takes a lot of times. You go into the hospital and it's so progressed or it's metastasis to somewhere else, and you don't really have this option. We could do the Whipple procedure, and that's what we talked about in that video. That's going to be so they can actually take off that head of the pancreas. They can actually help the cancer if it's not spread throughout. And those types of people will probably be in the hospital for many days, even weeks after the procedure. They'll probably be NPO before surgery, like most surgeries. Be on TPN for maybe a couple of weeks after, because they have to make sure everything's working. You're going to look for ileus, look for complication, look for infection, and you're also going to make sure the cancer is not coming back. Okay? Because sometimes that can be the issue is after a few weeks, you still start to have problems. NG tube for feeding. This is not necessarily a pancreatitis, so you can use NG tube feedings during this time. We just want to make sure that it's actually flowing through the system. So how do we evaluate if it's flowing through the system? Stools, making sure they're making stools. Okay. This is the Whipple procedure, how they talk about the anatomy and how they reconstruct it, getting rid of that head of the pancreas, the duodenum or the duodenum. They'll get rid of that portion 90% of the time, and they reconstruct it to get rid of that part. Okay, that video probably tells you a better picture of what it looks like rather than just writing it out. Here's another picture of the Whipple procedure, how it can reconnect, and they usually take the gallbladder out. Not always, but in that procedure it did. Okay, post-op care with the Whipple procedure, they will be in an ICU probably for many days. They are very, very ill, okay? If they had pancreatic cancer to start, they're ill anyway. Most of these people have to be cleared for surgery so they can actually go get this surgery done, okay? That's really hard in this population because they're already sick. And so after surgery, they might be ventilated, they might be on a lot of lines, they could potentially be have like central lines, art lines, and it's very scary for families to see this, so we have to prepare them and let them know that this is what they could potentially see. Okay. After the Whipple procedure, we want to make sure blood glucose is in check because now that we've manipulated the pancreas, the small intestine, we want to make sure blood sugars are actually staying maintained. If we potentially got rid of the problem. Hemorrhage, we could have nicked something, perforated the bowel, or even potentially made something bleed by touching the small intestine. And so we will look for hemorrhagic shock. And that could be the same as hypovolemic if they have those signs. Infection is probably going to be one of your more common ones because you're actually manipulating that area where there's stool. Obstruction, which we would monitor with bowel sounds, making sure the bowel sounds are evident, and then making sure there's no other infectious process with like an abscess. Okay. I don't think I read. Oh, I did. Okay, I just want to make sure. All right, 3 clicker questions, and then we'll review here. After receiving change of shift report on these clients, which client will the nurse plan to assess first? You don't really need to know anything about liver at this point. You just have to know your ABCs. A, right? They're showing respiratory distress or some respiratory problem, so they're going to trump any other patient. A person with cholecystitis, they're going to have right upper quadrant pain. That's not a priority on my list. A middle-aged client who has an elevated temp after undergoing endoscopic, I'm just going to say ERCP. I don't really know how high that temperature is. I know you can't really define that, but to me it's like, okay, they probably had a procedure, they're a little irritated. Older adult client who's receiving TPN after a Whipple procedure and has a glucose of 235. Well, that glucose isn't really that spectacular for me. I'm not too concerned about that. If it was 40, they may trump another person, but ABCs always wins. Okay? The client has undergone a Whipple procedure for pancreatic cancer. Which precautionary measure will the nurse implement to prevent potential complication? I put the answer on the bottom. After the procedure, we're going to make sure we check blood glucose, check for bowel sounds so there's no ileus, and then also monitor mental status because that could be related to infection potentially. So mental status will be monitored. Ensure the drainage color is clear. You're not going to get clear drainage. You're going to get bile-looking drainage if you have that type of problem or that type of drain. Place the client in supine position. We lay them completely flat. They cannot breathe. Okay, so we want to make sure they're elevated. They're probably going to be even intubated at that point. The client's just been diagnosed with pancreatic cancer. The client's client's upset spouse tells the nurse that they have recently moved to the area, have no close relatives, and are not yet affiliated with the church. What is the nurse's best response? What's significant about pancreatic cancer diagnosis? Not a very good diagnosis, okay? It's very, very troubling to a lot of families. We suspect, especially if they're telling you that they just moved to the area and they're not affiliated with the church. I know they're religious. We always offer chaplain services to any family or patient that would like it, especially if they're new to the area. They don't know what church they like. So it might be soothing for them to have a chaplain on board to talk about their options. And the chaplain in the hospital will actually go through the power of attorney process. Does everyone know what a power of attorney is? When someone speaks on behalf of you, if you cannot make decisions for yourself, okay? They actually line all that up. It's a legal process. They have to get it signed by someone that's authorized to sign it, and the chaplain will do all that for you. So that's why a chaplain is so significant in pancreatic cancer. Okay? Any questions on pancreatitis, besides what's going to be on the plan? All right, let's pull up our blueprint. We're going to go through this. We have about half hour, 45 minutes. Did you guys see on, we're not going to be able to go through the, I did have a Jeopardy type thing, but I'm not going to go through that. They're just questions for you to go through. It'll be posted at 11 a.m. today. You can go through that, and that'll help you evaluate if you actually know that you're studying enough. So I might wait to go through those questions till you study, maybe on Sunday morning or so, and see if you actually know what you've been studying. Okay? There's also on TigerNet these little hepatitis. Have you seen any of these? If you have not looked at them, they're nice little concrete study guides for you on hepatitis. You have to know every type of hepatitis, and you have to know how they're spread and what they're treated with. Okay? I'm going to ask probably, I think there's 6 questions on the exam. So it's pretty good information on TigerNet. Right. I'm not doing that camera thing because that camera thing, you can't even see the board anyway. Would you guys agree? Okay. We'll just listen to my voice. All right. We'll start with the first PowerPoint or the first slide. Kind of work our way down. Let's see. Cirrhosis. Came so long ago. So cirrhosis, we're going to start with what you guys think, based on the blueprint, what you guys think I would test on, or what questions you would think they would be on the exam. What have we stressed on? What do you think is the most important? Right. Signs, okay, we can start with signs. What are you going to see with patients with cirrhosis? Okay, let's talk about jaundice first. Jaundice. Okay. I know it may sound kind of silly that I've said some of this stuff 15 times, or even like the pathophys of why it's happening. But I promise you guys, you have to know the pathophys of every sign that's happening if you just okay. So jaundice. First of all, what is jaundice? Yellowness of the skin. Icterus. What is that? Eyes. Is that going to happen first, or is your skin going to happen first? Eyes. Icterus will happen first. Okay. You have cirrhosis. What's kind of the time frame? Like if you get diagnosed with cirrhosis tomorrow, are you going to have jaundice the next day? Maybe not. This could be years, you guys, before you see some of these symptoms of cirrhosis. Some people it happens faster, some slower. What do you think would happen in a patient that would make it stuck? Alcohol. Okay. Specifically with alcohol, what kind of cirrhosis? Planning. There's 3 types of cirrhosis. Lanix is going to be your number one. It's going to be your number one reason why someone gets cirrhosis because of alcohol intake. If you're having lots of alcohol intake, it's going to be directly related to your liver. And don't stop drinking. Let's speed up the process. We'll die of cirrhosis. Okay. What's our second one? Okay. So cardiovascular. I'm going to say this is probably your least common, but it's specifically related to what kind of heart failure. Right side. Why is right significant? Blood backs up into that process, and it can cause that blood to sit. It'll cause that blood to kind of sit there, and it doesn't move, and it can stay in the liver, cause pressure increases, and your portal hypertension. Okay. What's the third? Yep, biliary. That one's pretty common. We've talked a lot about obstruction, haven't we? Okay, so that's going to be directly related to an obstruction. That can be either through stones, but also through like a kinking or the anatomy of your body. Sometimes it's genetic. Sometimes you have no risk factor, you have no diet-related thing that's causing cirrhosis or causing obstruction. It just happens because you have a prone risk for it. But latex is going to be your number one with alcohol. Okay? Vaginas is going to be from bilirubin being obstructed, right? It's not being delivered properly from the liver, usually from obstruction. Okay? But also jaundice. What kind of meds do we give for jaundice? We can give Questron because of the bile salts that accumulate on the skin. That's obviously going to cause that jaundice color. So the bile salts on the skin. Questron. How is Questron given? Once a day, once a week, sub-Q, IM. It's going to be probably 4 to 6 times a day. And it's going to be given a powder substance. And you mix it with what? Like juice. Juice. Because juice is going to have a better flavor. Powder is gross. Really, really gross. And if you smell it, you're going to say, ugh, I have to drink this. Put it in with apple or orange juice, they like it a lot better. And the less drink, the better. So don't put it in like 10 ounces of orange juice. Put it in like a full shot of or. Okay. What other signs or symptoms? All right, ascites is a huge one. Ascites, you're probably going to have 4 questions on ascites, probably a lot. Okay, so why does ascites occur? First of all, what is ascites? Pregnant belly, right? Pregnant belly full of fluid. Why do you have that fluid just in that area? Okay, protein is going to be affected. If you think about people that have swelling of their extremities, they're going to have something called third spacing. If you have very low protein in your body, especially in your serum, on your outside, you're not going to have very much nutrition, I guess. That causes third spacing, causes that swelling of fluid. So it draws into the peritoneal space. It's like a pressure that builds in. Okay? You're going to have accumulate in the abdomen. You're going to have low protein, serum protein, or LPU.
You'll have low digestion.
You
have a low serum, but you actually
yeah, right, because it like attracts through a pressure all to your stomach. So the protein accumulates in your stomach, but your serum proteins are low, like the ones going through your system. You almost look like a stick person with a pregnant belly. They will have remember that picture of that lady who's pretty big, but her arms and legs are small. It accumulates all to that area. How do we treat ascites? What do we do first line? We're going to go do a paracentesis right away? Nope, diuretics. That's going to be a very common thing we do. What kind of diuretics? Give me an example of one. Okay, Lasix and spironolactone are going to be a common one. You can also give Bumex too. Bumex is another form of Lasix. It works the same way. Okay? What's significant with each one? Lasix first. Electrolytes, right? Okay, what does Lasix do? It gets rid of a lot of electrolytes, right? Specifically, potassium. Okay? What we want the medications to do is get rid of sodium and water. Lasix, that's a good thing, right? Get rid of sodium and water, but it also takes potassium with it, unless it's spironolactone, that it reserves your potassium. Potassium sparing. So what would we look for if a patient comes into ascites, they're on spironolactone, what labs are we going to look at? Okay, what would we expect their potassium to be? It might be high, okay? So they're retaining all these electrolytes, and if we're going to give a medication to preserve that specific electrolyte of potassium, they might have a potassium that's really high, okay? So we want to make sure that potassium can be checked. Are we going to get concerned? What's our normal potassium? Are we going to get concerned with 3.4? What about 5.1? No, don't do that to yourself. Okay, I know the normal is 3.5 to 5, but don't be to the point where you say, okay, it's out of the normal. Okay, look at O2 stats. We have one that's 91%. It's considered normal, but it's low normal. We have to kind of look at our trends to see what's going on. If you have a paracentesis, with our next treatment, what is it? You drain the fluid out. What are you going to expect for assessment after? Blood pressure will drop. What's considered normal? When do we get excited? What if they were 140 or and now they're 28 over 72? Are we excited? No. I know it's still normal, but usually we don't get excited until it's dropped about 25 points. Okay, that's what we look for. And symptomatic. Is your patient tolerating that fluid loss? What's our other thing that can happen from paracentesis? True, I'm talking more about like shock. Well, shock could be from your blood pressure, but labs. So we're looking at our potassium, sodium. We need to make sure they're not getting too low or taking off 4 or 5 liters of fluid. And now their potassium is 2.2, took off so much fluid. Okay, so we have to look at trends of electrolytes. Infection, what's that infection called? Peritonitis. And what would symptoms you look for? You have a rigid abdomen, look for white count increased. Potentially it looks red in that area if you got really infected in that area. But mental status changes, all the simple things that you would think of with infection. Okay? It's called SBP, it's something spontaneous bacterial. There you go. Okay, so that's what you'll look for with that. They'll culture the fluid that's coming off from the ascites to measure it. They'll make sure that it doesn't have that fluid in there. Okay, what else for ascites? Let's think of diet. Low sodium. You have to give them low sodium. Okay, that's going to be a must. What's that? Protein? I wouldn't get too caught up on protein with them. Right. You want lower in general, but some areas have low serum. I don't want to get too issue with that because some doctors might say yes, some might say okay. But for sure, low sodium diet. You want to make sure they have low sodium. Yeah, I guess if you're on spironolactone, don't eat a lot of potatoes. All right, anything else besides these? Yes, sodium restriction and water restriction. What's normal for water restriction? What's something that they tell us to do as a healthy individual? 8 cups a day. What is 8 cups a day? It's like 2 liters. We want to do less than, for sure, probably 1,500. That's probably a lot. Most doctors would probably say less than 1,000, but 1,500 would be a good rule of thumb. Because we're going to drink probably 2 to 3 as a healthy individual. Right, that shunt. What's that shunt we talked about? You have to know everything.
Denver is
okay. Right. You don't need to know specifically the differences in each. I want you to know what it's doing. Okay. So the Denver shunt and then the other one, Levine. They're very similar. One just has a little pumper that you put in, but they work the same way. You're going to redirect the ascites into systemic circulation. Okay. So what are you going to expect? That's what I want you to know. Okay. What are you going to expect is a positive thing once you install this shunt? Okay, you can assume your albumin might come up, not their spacing. What about urine output? Increase. Okay, urine output will increase because you're going to actually get rid of that ascites. Okay, but you could potentially have your blood pressure drop because you're starting to get rid of a lot of fluid now. Your electrolytes could drop because it's kind of like a paracentesis, but through your own circulation. So think of the same symptoms you would get with that. Okay, you lose fluid, your blood pressure might drop. There's a potential for obstruction. Remember, it can get dislodged in there. The ascites has a lot of particles in it. Get clogged up, so it can cause an obstruction. So what would we suspect in this shunt if it wasn't working? Yeah, your abdominal girth will stay the same or get bigger. You know it's not working. Pretty simple. Okay. All right, I think that's all. What other symptoms would you have with cirrhosis? Yep, total hypertension. The blood is portal hypertension. It's our biggest vein in our anatomy of our biliary liver system, right? Okay? If that is restricted with high pressure in there, what is something that you'll see? Emily gave it away. Varices, right? You can see varices, also ascites, but we'll go through this. Varices, hemorrhoids. Hemorrhoids would be the lower. Oh my God, you're gonna make hemorrhoids would obviously be lower. Varices in the esophagus would be higher. Okay? So what are those? They bleed, right? Okay, so what are we going to suspect maybe on assessment, or we're going to look for? Someone comes in and they have a history of cirrhosis. We suspect that their esophageal varices have ruptured. What are we going to see? Okay, they're going to be coughing up blood or vomiting blood. What about stools?
Dark red.
Dark. We're going to see dark, almost like tarry. Dark stool. If it's higher. So if it's already high in the stomach or in the varices of your throat, sometimes they drip down. Right. Nothing to stimulate those varices. Some people can have a history of esophageal varices and never have a problem with it. It's only when you rupture them. So things that can rupture them would be sharp foods, coughing, retching, sometimes exercises that cause you to like clench. They can make those rupture. Alcohol especially, irritants, medications that could potentially irritate it. What about medications that could potentially be detrimental to these people? Okay, blood thinners. I'm going to ask you questions. What about a person that's on, let's say they have heart issues, they're on 81 milligrams of aspirin. Is it good or bad?
It's probably be okay.
81 milligrams of aspirin is not that much, you guys. Most people, if I had a GI bleeder one time that came in, he was taking like 600, it's 325 is like the max you take of aspirin a day. He was taking 650 of aspirin a day. Okay, just straight up not educated on what that could happen. That's when you're going to start having exacerbations of your GI bleed or your varices are going to rupture. A little baby aspirin is not going to do anything, especially if it's occasional for pain. If they just take it as a older people, they don't take ibuprofen and Tylenol, they take aspirin for pain. Okay, that's okay. We might suggest if they are having frequent problems and they're coming in to maybe say, hey, maybe we can think of a different option for you. But if Plavix or Coumadin or Xarelto is on there, those need to be taken off. Those are way more detrimental than a baby aspirin. Okay. What if the stool, or what if it's bright red blood? Hemorrhoids, right? Or a lower GI bleed. So you have to know the difference. If something's bright red blood, I'm not as concerned with dark. When I think of dark, the higher the GI bleed, probably the worse it is. Okay? What are some interventions for esophageal varices? I'm thinking of one in particular, besides medications to reverse it. The tube. And tube. Yes, but I'm not going to focus too much on this. I'm going to tell you right now. I'm thinking of a Blakemore tube. Blakemore tube. What is it? Probably like, what did I get that? It's the tube that stops the... Okay? Your esophagus. Belly. Sorry, this is your esophagus. That's your belly. This is what it's going to look like. What they do is they put this tube down your esophagus in a little balloon. It's inflated like this, and it's going to push on all those little varices in your esophagus and hopefully clot them off and stop them from bleeding. Sometimes they accumulate in the lower part of your esophagus, right before your stomach. And then also there could be some right around the tip of the stomach. So they put that bigger one underneath. What do we have to know about this tube when you're a nurse? Scissors at the bedside, why? You couldn't find it. Patient migrates up. Right, if it migrates up, and it can happen, think about these tubes that get deflated, they start moving up, and they might push on your trachea, because your trachea is right by your esophagus. Okay? Just make sure you guys know that if that gets dislodged up and your patient starts looking like they're in respiratory distress, you need to cut that tube. Let's say you walk into your patient's room, they have a Blakemore tube, and they're sitting there. What's that? Yep, go right to their stomach. Yep. You just pull it out. Or we're going to talk about it. Okay, so go into your patient's room, they have a Blakemore tube, and let's say their SATs are reading 84%. Are you just going to start cutting that tube? No, you're not. If you cut that tube and there's no airway problem or obstruction, the doctor is going to slap you. Because this is a big process. If you cut that tube and take that tube out and there was never an airway obstruction or sats that were declined, seriously declined, that's a big process. The doctor has to come back in. They have to put that down. There's more complication. You just irritated that area. And so you have to make sure first of all anything that your airway is actually obstructed or there's an actual problem. Okay? You'll know because your patient will be struggling. Okay? Your patient's airway is cut off right now. If they're truly obstructed and they're truly respiratory distress, we'll know. But remember how sometimes you go into a patient's room and the SATs say 84%? Sometimes it's not accurate. You have to have that flap. Remember it goes like this? You know what I'm talking about? Yeah. Okay, so your O2 stat says 84% and it looks like this. I believe that. Okay? If it's 84% and it looks like this, that little line, I don't believe that. I do not get excited about that. The first thing you do is look at your patient, see what's going on. Here's why, guys. Make sure you guys are always evaluating your patient first before you get excited. Okay?
So if it's 84% and like that, snip that.
Okay? Well, you evaluate them. You go and say, okay, what's going on? Are they doing this? They can't breathe? Or are they just sitting there looking at you like this? Maybe they have pneumonia. I don't know, but maybe there's underlying respiratory problems that's not from the Blake-1 tube. Okay? Look and see if they're obstructed. Okay, that's the first thing. Next thing, what would you do? Okay, so we know it's obstructed. That's the first thing. We know they're struggling. That tube is dislodged up or emerged up. We know there's a problem. We have to get that tube out. Well, what do? We cut it. Scissors have to be at the bedside. I keep them in my pocket at all times. You should always invest in the scissors and keep them in your pocket. That's the one thing that you always like to have in your pocket is the scissors. You may not use it much as a student nurse. I never used it once. When I became a nurse, I don't know what I would do without my scissors. Cutting tape, cutting the IV, tape around for an IV line. Someone has to do CPR, I cut that gown. Like just things like that you got to think about. You don't want to have to go run to the nurse's station and get your scissors. Okay? But there will be scissors taped to the wall with a Blake-1.
I think I will.
Well, if they can't get it off, you don't want to waste time. If they have tons of lines,
You've done that?
Mm-hmm. Especially in the ED. If you don't have the scissors in the ED, you won't make it very long. You want your scissors.
That's intense.
What else is like? Okay, so we cut the tube. Now what do? We pull it out. We don't want to leave this tube in someone's esophagus. So we take it out, and then what do? We evaluate their airway, right? We make sure that they're breathing. Maybe apply some oxygen, making sure that they're breathing fine, lung assessment, and you probably should call the doctor. Not just put one in. He will be a lot happier with you if that was the reason, rather than jumping out because you thought the stats were low.
You usually get in order.
No, if it's an emergency like that,
Well, yeah,
yes. If you actually are taking it out because they're ready to be taken out, the doctor will give you that one. Okay? No. But they did 10 years ago. They just don't do it now. But yes, scissors will be essential. All right, what else is portal hypertension? What else does it cause? What about your spleen? Who produced? Oh, yeah, that's markers. Oh, yes. Your spleen, what happened to it? Enlarged. Why? Blood getting backed up into your system and cause your spleen to be enlarged. And what happens to what is your spleen? What's it do? What's it in charge of? Platelet. Okay? So what it does is that blood sits there and just pools, sits there for a long time. Your platelets will eventually die because it sits there, it doesn't get into circulation. So expect your patient with severe portal hypertension to have platelets that are low. And then once your platelets get to a certain lowness, can't clot off, then what are you going to do? You're going to bleed, right? You're going to bleed. What lab would you suspect would happen then? H&H will be low. Okay? H&H is low. You have to know what a normal hemoglobin and hematocrit. Some of you probably don't know hematocrit as well. I would suggest you know what it is for you. Okay? All right, what else? Portal hypertension. Meds. What meds would you give? Okay, we can start with a beta blocker, like propranolol. That's a good, nice preventative measure if nothing's ruptured and it's just portal hypertension that they deal with every day. Let's say that you actually have a problem now with esophageal varices rupturing. What med would you think of? Vasopressin. Not to know what vasopressin is and how it works. Okay? You think about vasopressin, what does it do to blood pressure? Increase. Vasopressin is a vasoconstrictor. You might think, well, geez, we have portal hypertension. There's already a lot of constriction in there. Why would we want to do that? Now our varices have ruptured, and now you're hemorrhaging, and you need to constrict those vessels, making sure that they're clogging up, not bleeding. Okay, so vasopressin is going to be your number one you give for an actual disease. You're actually bleeding, not your preventative measure. Propranolol is what you give as a preventative every day for esophageal varices when they're not ruptured. What other meds? Okay, Sandostatin, but remember that's the one that is not really, it's an older one that are people coming out. If you're actually bleeding, what meds could you give to reverse the bleeding? Vitamin K. And it's especially good because what does your liver do? It makes all those vitamins, right? The fat-soluble vitamins. Your body's already lacking vitamin K, so it needs more vitamin K. You give FFP, plasma, to stop it as well. And you'd obviously give blood products if your hemoglobin was low enough, or if you're actively throwing up blood. Okay? What else for cirrhosis? PSC. On your blueprint, 3 questions. What is PSC? Hepatic encephalopathy. Yes. Mental changes, okay? Why? Why are you having mental status changes from your cirrhosis? Okay, so your ammonia is high. I love this part. Okay, so ammonia cannot be broken down in your body. What does ammonia get converted to? Urea, okay? Usually gets excreted in your urine. That's why your urine has ammonia in it. Makes sense, right? So if you can't get rid of your ammonia, what's the first thing you're going to find that your patient's going to try to have? Mental changes, their level of conscious change, and they might become agitated, and even in later stages, there's 4 stages of PSE. You do not need to know those 4 stages. Just know 1 is the best, where they start to have initial signs. 4 is a coma. Okay? They initially will have signs of irritation, agitation, and all of a sudden they get drifted away, and then they become lethargic, and they will die if their ammonia levels are too high. Okay? But what are you going to do as a nurse if you come onto your shift and you have a patient with cirrhosis and they have some suspected signs of hepatic encephalopathy? What drug are you going to maybe anticipate? How does lactulose work? Read it in the poop, okay? Read it in feces. What are you going to expect? Yeah, fun shit if you see lactulose on your MAR. You see that, usually the nurses draw for straws because it's every 15, 30 minutes of draw for straws. Ideally, we want to see them have 2 people to shift. That is never. There's no happy medium of lactulose. The doctor will just say, make sure you watch electrolytes, watch for fluid volume elimination. We don't want them to get hypovolemic shock because they're pooping so much. So we will be watching electrolytes probably at least every 6 hours on these patients, and they'll get their labs drawn, and they'll get lots of fluid. Okay, to make sure that they're not losing too much of their fluid in their body. Okay? So let's say the ammonia is high when they come in. We give lactulose. How do we know if this med's working? They should start to pooping too, but they should start to wake up and start to be more coherent. Okay, it's wonderful when they go from, well, not when they first come in, when they're very agitated, they are incoherent. When they start to get more improved, you're like, yes, pneumonia is starting to come down. Go back. Okay. What are symptoms of PSE? What would you notice besides level of conscious? What other symptoms? Asterixis. Asterixis. Okay. What is that? Your fingers kind of have a little bit of a tremor in them, I guess, is what I call it, tremor. You'll see that. What else? What is apraxia? What's apraxia? Apraxia means you lose that function to like write. You can't actually draw. You can't actually function with obstructional apraxia, extends you can't actually do obstruction. There's one more I'm thinking of. There you go. Feeder hepatic. It is the smelliest breath you ever smell, and you'll smell it when you walk into the unit. Feeder hepaticus. And so what you do is you'll notice right when you walk in the patient's room, it's just like a fruity, poopy smell. Okay? That's what it smells like. It smells like it's definitely foul, not a good smell. And the sweet is almost not good. But you'll notice when it's kind of like smelling GI bleach time, which some of you did yesterday. You'll never forget that smell. Okay, same kind of smell. Feeder hepaticus. No one ever calls it this in ICU. If you ask all nurses, they probably wouldn't know what that term was. But if you ask a person in the ICU or even on the medical part, if they've ever had a patient with cirrhosis or liver failure and had to give lactulose, they say, oh yeah, they're breath. Okay? So those are the things you've noticed for PSC. What other med could you give besides lactulose? Neomycin. And how does neomycin work? Man, Emily, you're smart. I listen to this, yeah. Okay. It wrote everything. So neomycin, essentially, it kills that bacteria, that flora in your GI tract to make sure that it can actually excrete the ammonia. It's the same process. It makes the ammonia not get produced more, not producing more ammonia. It has to do with ammonia production. And you will get both of these, but lactulose is quite more common. What else for PSC? I think that's it. All right, any questions on cirrhosis? I think you guys actually covered a lot of it. Not so hard when you put it up here. It's actually pretty related to our second PowerPoint. Comes back and it's all right, we'll talk briefly on cholecystitis and cholecystitis. Okay, someone comes in with cholecystitis, what are you going to see first? Right upper quadrant pain. That's the first thing we're going to suspect that this is even a problem before we do labs, before we do diagnostics. We're going to come in with right upper quadrant pain. Sometimes it can radiate to the shoulder, go up behind there, and even into the shoulder blade on the right side. But if someone has left upper quadrant pain, we wouldn't suspect this at all. Okay, so just make sure you know your areas of how it works. Okay, so what is cholecystitis? Gallstones. What are gallstones made up of? Cholesterol, and also it's like a pigment. Yeah, pigment is not as common. So I'm going to focus on cholesterol for your exam. But obviously, if it's made up of cholesterol, what can that tell you about their diet? High cholesterol, high fat. We want to make sure that when they're, some people don't get their actual gallbladder taken out. We have to encourage they go home on a low fat, low cholesterol. Okay. What are some procedures we can do for cholecystitis? What can we do to get rid of those butters besides take out the coal?
Vibrating.
Vibrating with something?
The weight one.
Oh yeah. Shockwave therapy.
I said vibrating.
I was like, who said vibrating? Okay.
I'm just thinking of the weight.
What are some indications? Why would we do this, and how do you not do this? We want to make sure that we actually have qualifications.
3 stones.
Yes. 3 stones or less, but 30 millimeters. I know what you meant. 30 millimeters, which is how many centimeters? It is 3 centimeters. Research is now showing 2. It's more effective in less.
Yeah, I was going to ask what
I'm not gonna ask. Just know it has to be sized. You can't have a huge one in there and expect it to be. What's the other one? How many? 3. That's not very many. Most people have more than 3. So shockwave therapy might be in initial stages, and it's if they catch it early. So how does it work? You shake them all up. It's excreted through what? Is it in your urine? Or in your stool? Why is it not in your urine? Because it's in your GI. It's not in the kidney. If it was in your kidney for a kidney stone, that would be excreted through your urine. So that's why people that have kidney stones, they do those strainers. Have you ever seen the strainers they put in people's rooms? When people pee every time, they go through a strainer and you can see if any stones have passed. You don't have to do this with GI. You're not going to be able to tell them. They're very, very small. What else for cholelithiasis? Medications. I think it's the Xanax. It ends in dial. That is your generic. It's going to be something you give to people, usually weeks at a time, and it's someone with chronic gallstones that come in, and it's going to dissolve those like ball. Some people always have gallstones in their body. They're not officially gone. They're just small enough where they can pass. Okay? And that's why those medications are initiated. If it becomes bad or they get obstructed, they're going to have pain, right? It's going to hurt. And if it happens a lot over time, the doctor will take out the gallstone. Okay? But it's not the first thing we like to do because there's a high risk for infection. It's an unneeded surgery if you don't technically need it. You want to make sure that you're not going strictly right to surgery every day. Okay? Again, with cholelithiasis, you can have nauseousness and vomiting, some generalized symptoms, but right upper quadrant pain is going to be your definitive symptom that you're going to know it's gallstone. What are some diagnostics? Ultrasound is going to be your first one. X-ray is okay. The reason they do an X-ray is to rule out other problems like peptic ulceration, GERD, but it's not going to actually diagnose cholelithiasis, and ultrasound will. Ultrasound is going to show if there's obstruction, make sure there's nothing getting stuck in those ducts, and also the liver's working properly. So ultrasound will be first. Chest X-ray is not bad. I'm not going to say that that's wrong, and I'm not going to confuse you in the exam. I know I did say that those are the first things they would do. Chest X-ray just doesn't diagnose gallstone. You might see a couple, but an ultrasound will do the best diagnosis. You can do a CT scan, but they try not to do invasive. But ultrasound will be number one. Let's see here. Surgery. Go laparoscopic first. I'm looking at your liver quizzes. Some of you have not taken it, so you might have an advantage here. Because there are a lot of you who are getting the laparoscopic question wrong. And the reason why is because it's laparoscopic and not open. That's all I'm going to say. Okay? But with laparoscopic, what are some things you want to know? What's going to happen during a lap Foley? Three holes. It's not going to be open. But what are we going to have less risk of? Infection. Less risk for infection. And also bleeding. And also complications if you think about making someone, but not open. And you're going to have 3 holes. And what do they put over those holes? Sometimes they don't even put anything, guys. They might put a Band-Aid or even a steri strip, but it's not going to be a bandage or an ACE wrap or a abdominal pad. There's not going to be anything over that wound. So essentially, no wound care. When can they shower? 24 to 48 hours. You should tell them the first day, as long as no signs of oozing or any type of infection, 1 day is fine. When do they get out of bed? Right away. We don't waste time. Go back to work. When they go back to work? A week. They usually let them have a week and they go back. And that's just to kind of help them get back to moving, get back to their normal routine, and make sure there's no complications. Let's do an open. What's significant about an open? Obviously, it's open. You're going to have an incision. You're going to have wound care. Could you have a drain? Yep, what kind of drain? AP drain, and also you have a T-tube. Why would you get a T-tube? A T-tube are a routine thing for a mixture. Right, so if you're manipulating that common bile duct when you go in for the gallbladder, sometimes that can cause it to spasm and almost become kinked or occluded. And so that's why they put a T-tube in. A T-tube is essentially a stent. It goes into that area so then it can drain out bile if it becomes too occluded. Right? JP drain. What's significant about JP drains? They're bulbs, right? These are not a suction device. You actually have to plunge the bulb in order for the suction to work. JP drain colors can vary from many things, but what's the most common? Stereosanguinous, the color we're looking for. What color is stereosanguinous? Is the other question. In this word, what does sanguinous mean? Blood, spirits is yellow. Okay? You don't want it to be strictly all yellow the first day. You also don't want it to be all French red clotting blood the first day. Usually by day 4 or 5, that JP drain is out. Okay? Heating can last about 2 weeks, depending on how severe they may be in that chronic bile duct. For wound care, you will see an abdominal pad usually over that gulf or over that incision, and usually it's changed per doctor discretion. There's no rule on that. You don't have to change it daily or every 2 hours. It depends what the doctor wants or if there's a lot of drainage. What's normal for a JP drain for drainage in 1 day? Everyone's different, I understand that. But what would be something that you'd be cautious if it was over a certain number? A liter. If it was over a liter a day, you'd start thinking, whoa, this is a lot of drainage. Let's say you had a patient that had a JP drain, and every hour they had 60, 40, 20, 60, and 5. What would you think about that hourly output of your JP drain? It's only been, this is from surgery, 1, 2, 3, 4, 5, 7 hours. Would we expect at 7 hours for your JP drain to be taken out? No. And if it's decreasing from 60 to 10 to 5 to 2, what's that tell me about the JP drain? There's an obstruction or there's something. There should be more drainage coming out of that tube. Maybe on day 4, I would expect, okay, we're getting like 5 an hour. That's not very much. But you should see a decline. Also, when else would you be concerned? If it's going low, and all of a sudden it goes high again. Like say for 2 days you had 10 an hour, and all of a sudden now you're having 50 an hour. Like it's increasing. You might suspect there's more infection or more process going on. What else? I don't know. We talked a lot about pancreatitis today, so I don't think we need to really talk about it. Oh, we got pancreatitis. Yep, you can milk a JP drain. You shouldn't milk a chest tube. That's what you're fighting. But yes, you actually they recommend you milk JP. So if that was obstructed, I might start milking that and see if that would help it kind of come out. You would never put saline in a JP drain. You would never clamp it unless the doctor said it was time to. And then you'd get a chest x-ray on a JP drain to make sure it's time to come out, and the doctor would tell you that. With a T-tube, you can clamp that and also make sure that you put saline in there, but never do it without a doctor's order. If there's nothing in the question about a doctor's order, don't do it, okay? It'd only be if they could do it. Right, a T-tube, you'd clamp around meal time, like an hour before, hour after, so then those files digest.
How long do they usually?
Could be, I mean, for sure, probably 4 or 5 days, but up to a couple weeks. So they could go home on a T-tube. And then what's significant about bile on the skin? Very bad. It could be bad because it can excoriate it.
I don't know. But the T-tube, they have to surgically remove that.
For a T-tube, yes. It's not something you just pull out. They have stitches in there, and a physician would do that. Probably as an outpatient.
Is there a risk for infection?
What's that?
Is there a risk for infection?
Yes, absolutely. Especially with JP drains too. And they like almost pull off the skin in a JP drain. They stitch it on there. But I think the JP drain incision site hurts more than the incision site because it like pulls. I don't know. Like, all that. Yeah. Great. Yeah, doctors are for T-tube on clamping, irrigating, or bleeding, I guess. All right, we're going to talk about hepatitis. The nice thing about hepatitis is that every single one of them has the same symptoms. Okay, there's going to be no surprises, tricks. If there's one symptom for one, it's for the all. Okay. A and E, I'm going to talk about them together because they're transmitted the same, and they also are fairly treated the same. Okay, so how do you get Hep A and Hep B? Oral. What do you think of when you think of oral? I think of washing hands, right? I think of people that go to work at Subway. They didn't wash their hands in the bathroom. Now they made my salad. Now I'm eating it. They have Hep A, Hep B. I'm just telling you, that's how it gets spread. Okay, that's why you always want to wash hands. Wash hands. Safe food preparation. Safe food prep. What about other countries? Their sanitation is not good, And so when we go to their countries, we try not to drink their water, mainly because our digestive system is not used to it. They have done it their whole lives, not saying that it's healthy, but they have done it for a long time, they're used to it. So other countries' water supply or their water is gonna,
Oh, would they have that?
not necessarily, but we may not even be used to any type of, we have filtered water and it's very clean. And so any type of bacteria could actually upset us. But yeah, look at it. Let's see, Hep A, Hep B. Are there vaccines for Hep A or Hep B? Hep A has one. Hep A has a vaccine, but Hep B does not. No. Okay. What medications for Hep A, Hep B? There's not really. There really isn't. You can get rid of Hep A and Hep B. You don't have it forever. It's not like Hep C. You probably will have it forever. You get this, and usually time, but we tell everyone the same thing. Rest, hydration, and eliminating your risk. Okay? So don't go back to that country if that's a problem. So rest, hydration. You can get kind of nauseous and have vomiting. So you might take antiemetics if they're in the hospital for that reason. That's pretty obvious. If they're having the symptom, give them the medication for it.
How long do they usually?
Sometimes the incubation period or when they actually get it can be a couple months. So they might have it, like say you went to Mexico for spring break, and you may not have symptoms until 2 weeks. Okay? So there might be, and I'm not going to have you memorize those periods of when you would get it. Just know for all of them, you're not going to see symptoms the very next day. When you came home from spring break and you started having problems with like GI upset, you don't have Hep A. Okay? That's not, you probably just have some traveler diarrhea. Okay? Or you drank maybe your water, not that you've got Hep A, but you got sick from that.
How many diagnosed?
There is titers. They can do that in the blood, and they will see if you have Hep A or Hep B. If someone is going to another country, we strongly advise Hep A vaccine, okay? And that will protect you against all Hep A. Okay? So vaccine, hydration, rest. That's what you're going to need. What's that?
Like, our normal population.
Right, not everyone. Nope. Some people have not got Hep A because I think colleges require it. I think it's just because I remember I got mine because I think I was going to nursing school. I think might have required it, but just because you go to college doesn't mean. Okay, C. This one's probably going to be the most, I don't know, potent or the worst one you can get. Nobody wants Hep C. One thing with all the hepatitis, there's no precautions for that. There's standard precautions, but you will not be on contact. Okay? You may gown up for someone that has Hep A if you're getting directly with their feet. But if you go in and do their blood pressure, you don't have to gown up. Okay? That's not a standard across the hospital system. It's also another liver quiz question. Because at one of them, everyone wanted to say or be on contact precautions. That's not the case. They are standard precautions. So Hep C, how do you get Hep C? Sex, hugs, and blood. Especially, I believe it's 1992, before 1992, if you got a blood transfusion or if you specifically were doing anything, with people potentially might have a higher risk. Because if it was, like for drug trade, like they didn't do as much filtering in your transfusion of blood. Think about actually getting blood. That's why there's higher cases for AIDS, even though it's almost obsolete now. We'll find it in their blood.
Amen.
Wait, what?
I put on the news yesterday. Somebody came.
Well, why can't they really?
Yeah.
I mean, you can get HIV and hepatitis
Into
from any sexual activity.
into one.
Right. I mean, there's a lot of stipulations for different types of people, and stigma back in the 80s, 90s that gay men, especially
They all had.
anal sex, right? And so there's more chance for anal transmission. But I think that's kind of a not racist, but sexist. I don't know what you think. Yeah, like to me, it's kind of like being. Okay, so hospital workers, Hep C is probably the number one that you're probably going to transmit because of why? Needle sticks. Okay? We as hospitals would like to make sure that needle sticks are prevented. What do we educate people to do? Don't wreak out needles, especially after you hold somebody. That's silly. Never do that. Make sure that the sharps box is within reach. You don't have to walk across the room if you don't have to. You have a high risk for tripping or poking yourself. You want to make sure that that's still there. No, we're just reviewing. Oh, okay. Is Lene in here? No, she's in class. No, we're just kind of reviewing. Okay. Hep C, is there a vaccine? No, but they're really close, which is great news because research is specifically focused on Hep C to find a review or find a vaccine, and they're really close. I would say in the next 10, 20 years, you would start seeing Hep C vaccine. Okay?
Is that usually result in different?
Yes, Hep C is going to be one of the common ones that will go back, and this is hard to get rid of. If you have Hep C, it's not very likely that you will get rid of it, unless you. It's not one that you'll technically get rid of, especially if the reason why you got it was drugs and alcohol. So that's telling you a little bit about your lifestyle, and you're probably not giving up some of that lifestyle, and that's why Hep C would be harder to get rid of. Okay? Hep C, I believe, is great. Immunoglobulins. That is a treatment you can give. Immunoglobulins. That's going to help just kind of not make the, in the initial stages, it's going to help you so it's not as advanced. And there is a chance you could get rid of Hep C. Just because you get Hep C doesn't mean you'll have it forever. But I'd say 75 to 80% of people won't get rid of it. And it will result in liver cancer and liver failure. What else on that? B and D. The reason why I'm pairing those together is why. If you get Hep D, you don't have Hep B. You have to have the Hep B inside your body to get Hep B. And most of the time they're hand in hand. Is there a vaccine? For B there is. Hep B, B as in boy. Hep B series, 3 of them. You can get that. So essentially, if you get the Hep B series, you are essentially immune from B. Does that make sense? Because you can't get B without having B. So you got a Hep B vaccine, but technically there is. Okay? Just know if you have Hep B, you'll get it. They're paired together. How do you get B and B? Right, body, fluids, same way, sex, drugs. Saliva is not by kissing, but if you got bit by a patient in the hospital that had Hep B, they can shoot. I'm not going to shoot for that either. Okay. Another question I know one of the clicker questions had someone brushing their teeth, and it was for Hep C, and someone goes, you can't get that by oral, but what happens when you brush your teeth? Your gums bleed, and so that could potentially cause the spread. If you kiss someone with Hep C, you're not going to get it. Okay, unless they had a full month of blood, you're not going to, probably wouldn't be probably not. But the main thing I want you to know is that there's no precaution, there's no contact precaution, all the symptoms are the same. The ones that have vaccines are Hep A and Hep B. Right, Hep A and Hep B. C is very close, but they don't have one, and then D essentially kind of has one, because B is just covered. Okay? Transmission, you also know each one's transmission, which you guys fairly know. Alright, any questions? Or anything you want me to elaborate more on that you don't get?
What are you going to do for silence?
You will see one thing, right upper quadrant pain, because think about the liver, it is hepatitis. So right upper quadrant pain, if left upper quadrant pain is an option, that's probably not the answer. Nauseousness, vomiting, fatigue, jaundice in later stages, like Hep C, you'll get jaundice. I guess ascites too, but that's more related to liver failure, not the hepatitis. Sickness, you'll get GI symptoms, you have the flu. And so people mostly will not think they have Hep A or Hep C because they are just having flu-like symptoms.
And how do you test for it?
There is a blood test for each one of these, and it's called a titer versus net, and they will see if it's elevated. Sometimes you can.
They only have to do one titer and take all of these.
Yes, you can. It'll just be one time. You don't have to do it more than one. And if you have symptoms of hepatitis, which most doctors won't even test for this because they don't suspect it, unless you've told them that you've gone. You have to do a thorough assessment. Like if you have, yes, if you went to another country, you've had sex with lots of people, you've been an alcoholic, then they would test for you. It's not something you're going to come to ED with GI symptoms and say, let's test for all hepatitis. No, you're not going to do that unless you suspect it is. Or preventing.
Leftover quadrant.
Leftover quadrant, the only one you're going to have to know is pancreatitis. And then if you have like MI, like a heart attack, or you have pneumonia. If you have right lower, what do you have to suspect is right lower? Appendicitis. Okay, which we're not even learning about that. But just so you know that that's the difference. Any questions? And I feel like we went over pancreatitis pretty good today. I don't think we need to go over.
So for hepatitis, if we go over like the slide that had like all on it, like
The symptoms you need picture. Yeah, I would say it's a pretty good one. The only thing is treatments aren't on there. Like you have to rest. Right, nutrition, hydration. But there are some that you can give like immunoglobulins to. I would pay attention to the treatments on those.
Is that only for A?
For immunoglobulins, no, Hep C.
I meant C, yeah.
Yeah, Hep C you can give something called Pegasus. That's a type of like kind of a antibody, and it can help. But like I said, Hep C is hard to get rid of, and that helps more with symptoms. Liver transplant. Liver transplant. Oh, that's something we didn't go over. That was on the slide, like the 10 PowerPoints that were left that we didn't go over from before spring break. Remember with the transplants, with the ones we learned last semester, they have well, right. You want to make sure they quit drinking, but if they get a liver transplant, you want to make sure that they're not having reactions or what am I trying to think of? Not obviously complications, but rejection. Rejection. That's what we're looking for, and that's what I'm going to focus on the exam for liver transplant. First signs of rejection are going to be what? Fever and pain. Like you're going to have lots of pain, and it's going to be irritated. Potentially you might get sick from it, like nauseousness and vomiting. And then what medications would be what you would give? Which they're probably going to be on this anyway, but like that. Steroids, corticosteroids are going to be your number one. What's an example of a corticosteroid? Prednisone or Solumedrol. That's going to be a very common one. Second line, cyclosporine. Remember cyclosporines and our rejection? That would think you're going to have. They're already going to be on those meds anyway because they have to have that on there for any type of transplant so you don't reject it, but they'll be increased. They'll be given more during that time. And what's a sign that you're getting too much steroids? You could potentially have signs of what? Infection. Because you're lowering all their, totally different, but you're lowering all your immune system, so they might have a sign of infection somewhere. So make sure you're monitoring for infection. Yeah. What else? Liver trauma. Liver trauma is probably more related to like the shock state. If you actually have a traumatic experience from an accident or you got a stab wound to your liver, you can have signs of shock, like hemorrhagic shock. And so think about treatments for shock in that regard. Did you guys see the bottom here? All those meds? Yeah. I nicely did this for you because it's kind of hard to know. So I think we talked about a lot. Tiger is probably going to be your most new one that you've never really seen before, but you have to know that that's for nauseousness and vomiting. This is the one I was telling you about, those stones, where it can like release those stones.
Absorb?
Right, they can absorb it and they can make them smaller. And it ends in DIOL. So if you're wondering for generic, it's easier to remember that.
When you use Tiger for liver failure patients, right?
Right.
Because Zofran's broken down.
Right. And they still do give Zofran if it's not a severe case, but Tigan might be given to people that can't tolerate it as well.
So is that broken down these?
Yep. So essentially, if you have kidney failure, all medications are potent on your body because kidney excretes a lot of meds. We talked about cholesterol. These enzymes, you have to know that because that's going to be used in what diagnosis?
Pancreatitis.
Pancreatitis, because they're going to be on enzyme replacements. This Gemzar is going to be for pancreatic cancer. That's a chemo.
You have to know that?
Just know that it's chemo. You don't have to know how it works. Just know that that is a chemo. Vasoactive drugs, we talked about propranolol and vasopressin. We know that Tylenol is very potent on the liver, so you would never give Tylenol to someone that has liver failure. The PPIs and the histamine receptor antagonists, I want you guys to know those especially well, because that's going to help coat the stomach and it's going to help prevent GI bleeds, and it's also going to be nice for the body so you don't have to worry about breakdown. Diuretics, you're gonna have to know that. We talked about that. Here's the liver transplant rejection meds. You have to know all those, you guys. They all work the same. That's the good thing. But you need to know which one you'd use first in a liver transplant rejection. Which one is that? Polymedrol.
Those kind of go in order then?
Yeah, we use corticosteroids first, and then cyclosporines, and then we do use these other ones as well. Okay. I wouldn't focus too much on this one for ascites. Just know with paracentesis, you can have that bacterial infection, and you're going to give antibiotics. I'm not going to get too picky on which antibiotics you're going to give, but it makes sense that you give antibiotics. And all the other ones we pretty much went through. Here's the Hep C meds that you have to know. And that's the only one really that has a technical treatment. Everything else is rest, hydration, and making sure that you're just kind of recovering, like making sure you're going to the doctor to be evaluated.
And the only way you can get rid of Hep C is to get a needle to treat it right.
Right. And so they'll usually give you these medications. So that's a good example. If you're in the hospital, you get a needle stick that had a patient with Hep C, they would give you these meds even before you even tested positive to make sure that you could prevent it. And that is why those cases are reversible, or you can get rid of them. But alcoholics that have had it for years, they're not getting rid of it. Okay? So when people come in, we get really specific about Hep C. We can't do anything about it. We still are giving standard precautions, washing your hands, but we're extra cautious about needles and making sure we're not getting them because it's hard to get rid of. And I actually know nurses that have gotten stuck with Hep C patients, so it does happen. I never really followed up with them. It's not something you ask them 6 months later, hey, do you have Hep C? But I know that they had to do all the precautions for it. All right.